Good morning and welcome to the 30th meeting in 2013 of the Health and Sport Committee. As usual, can I remind all of those present to switch off their mobile phones, Blackberries and other wireless devices, as they can often interfere with the sound system. Members of the public may also have noticed that some members and officials are using iPads and other tablet devices, and this is instead of the hard copy of their papers. We have apologies this morning from Richard Simpson and Aileen MacLeod, and Malcolm Chisholm is with us as a Labour Party substitute for Richard Simpson, and we welcome Dennis Robertson back, Dennis, to the Health Committee as the SNP substitute here this morning. Welcome, Dennis. The first item on the agenda today is the decision on taking item 3 in private at today's and future meetings. Item 3 is the committee staff Stage 1 report on the Public Bodies Joint Working Scotland Bill, and we normally take draft reports in private. Can I have the members' agreement to take item 3 in private? Thank you. Item 2, which we now move to, is the annual process of scrutiny of the Scottish Government's draft budget. And this morning we are taking evidence from the Cabinet Secretary for Health and Wellbeing. Can I give a welcome on behalf of the committee to Alex Neil, Cabinet Secretary for Health and Wellbeing. Thank you for being here this morning, Cabinet Secretary. We also have John Matheson, Director of Health, Finance, E-Health and Pharmaceuticals of the Scottish Government. Welcome to you. I invite the Cabinet Secretary to make some opening remarks before we proceed to questions. Cabinet Secretary.
That's great. Thank you very much indeed, Convener. The Scottish Government remains committed to publicly funded healthcare services for the people of Scotland, which contribute directly to growth in the Scottish economy. The contrast between Scotland's approach to the NHS, based on its founding principles, and the competition and privatisation being introduced in England is growing ever more pronounced. NHS Scotland does not seek to promote competition. High-quality health provision is provided by a variety of other means, including efficiency and productivity initiatives, both centrally and within individual boards. Our record of achievement is recognised internationally as innovative and aspirational in its scope and potential for improving health and health care. Our achievements have all been undertaken within the context of the most dramatic reduction in public spending ever imposed in Scotland by the UK Government. Within these constraints, we continue to deliver on our manifesto commitment to pass on the Barnett consequentials to health. Resource funding has increased by £285 million in 2014-15, and NHS territorial boards will receive allocation increases of 3.1% in 2014-15 and 2.7% in 2015-16, increases above forecast inflation in both years, reflecting the importance that we attach to protecting frontline point-of-care services. We remain committed to investment in capital and infrastructure. During 2014-15, capital funding of £150 million will be provided for estate maintenance and equipment replacement, and £111 million will be earmarked for the Children and Adults Hospital element of the New South Glasgow Hospitals project, with a further £27 million to complete it in 2015-16. In delivering and improving high-quality and sustainable healthcare services, our record of success includes significantly reducing waiting times for diagnosis and treatment, the introduction of the Scottish Patient Safety Programme, with Scotland now regarded as a world leader in patient safety, major reductions in levels of healthcare-associated infections, improving mental health wellbeing and services, and creating a new relationship with industry and research to pursue a joint agenda of healthcare improvement and economic growth through innovation. We've also made a significant contribution to the marked reductions in mortality rates from the three big killers: cancer, heart disease and stroke. This includes the Detect Cancer Early programme, a £30 million investment concentrating on lung cancer, breast cancer and colorectal cancer. Over the next few years, the demands for health and social care and the circumstances in which they will be delivered will be radically different. Our vision is that by 2020, everyone is able to live longer, healthier lives at home or in a homely setting. For 2014-15 and 2015-16, spending will be prioritised in further improving the quality of care we provide, improving the health of the population and securing the value and financial sustainability of the health and care services we provide. Key priorities for 2014-15 will include increasing the role of primary care through a focus on keeping people healthy in the community for as long as possible, integrating health and social care as part of the Scottish Government's commitment to public service reform, accelerating safety improvement programmes in all healthcare environments by extending the patient safety programme to maternity services, paediatrics and mental health, driving forward the Early Years Collaborative, reducing health inequalities, particularly in the context of benefit cuts that will have the greatest impact on those at risk of ill health, preventive health measures on alcohol, tobacco, dental health, physical activity and early detection of cancer, and establishing a vision for the health and social care workforce for 2020 and setting out a clear plan of action. We continue to maintain a high level of investment in NHS Scotland infrastructure. Work continues on time and on budget on the £842 million New South Glasgow Hospitals project, which is due to complete in spring 2015. The official opening of the £70 million mental health project at the Murray Royal Hospital in Perth, the first non-profit distributing health project to be delivered in Scotland, took place in June 2013. Procurement for a further 4 such projects commenced in 2013, having a combined investment capital value of £440 million. The Scottish Government is working with key partners to ensure that the 2014 Commonwealth Games are an outstanding success. This success will include ensuring the Games have an impact beyond the 11 days of sporting competition. For example, in the East End of Glasgow, housing development for the Athletes' Village and supporting infrastructure will promote sustainable economic growth. To summarise, Convener, despite the biggest reduction in public spending imposed in Scotland by any UK government, this government is committed to delivering on health. Furthermore, NHS Scotland continues to be recognised internationally as innovative and aspirational in its scope and potential for improving health and healthcare. We continue to deliver on our manifesto commitment to pass on the Barnett consequentials to health. This means NHS territorial boards will receive these above-inflation allocations for the next 2 years, and we will continue to focus on further improving the quality of care we provide through the Healthcare Quality Strategy, securing greater integrated working, prioritising anticipatory care and preventive spend, prioritising support for people to stay at home as long as appropriate, and taking action to ensure that people are admitted to hospital only when it's not appropriate to treat them in the community. Thank you, Convener.
Thank you, Cabinet Secretary. I think the first question from Richard Lyle.
Yes, good morning, Cabinet Secretary. In a recent Audit Scotland report, it stated that NHS has made good progress in improving outcomes for patients, for example, reducing death rates from heart disease. But there were signs of pressures in the system in 2012-13. Not all boards have met their waiting time targets. Boards have spent more on agency and bank nursing staff and private sector healthcare. In fact, I'm led to believe this spending is up by nearly a quarter, some £80 million spent on private sector healthcare. What is your opinion re this spending on private health sector healthcare agency and bank staff, and do you believe we have too many targets introduced due to political party requirements?
Okay, there's quite a lot of questions in all of that.
Cabinet Secretary. So it's up to you.
Absolutely. Can I first of all say,
well done,
inevitably, there are, and I think will always will be, pressures on the health service because of the ageing of the population, the increase in the population. We've got a record population in Scotland. And if you look at the figures of people who have been through the health service last year, we had 1.65 million presentations at Accident and Health. We had 6 million presentations and consultations in the acute sector with doctors. We had 24 million consultations in the primary care sector with doctors. More than 50% of over 65-year-olds are in more than 5 medicines, 5 tablets per day, and it goes on and on and on. So these figures are huge figures by any standard. Therefore, I do accept that clearly with an ageing population, with the financial constraints that I referred to earlier, and with the fact that we've got a record number of people living in Scotland, inevitably demand pressures are very high. And a key part of our strategy going forward is to better manage the demand, for example, in terms of presentations at A&E, presentations at primary care surgeries, streaming of these patients and so on. Happy to go into more detail on that. On the specific issues, first of all, of the private sector, let me first of all say, to get this into perspective, south of the border, the private sector accounts for 10% of the entire £105 billion budget for the health service south of the border. So well over £10 billion is spent on the private sector, and that is rising, deliberately rising, because of the reforms that are taking place south of the border. In Scotland, the equivalent figure is 0.8% of our total £12 billion budget is spent on private healthcare. That obviously excludes the independent GP and dental contractors, because they're not, for the purposes of that question, I don't think regarded as private sector. And there's no doubt, particularly in the Lothians area, there has been an increase, a temporary increase, in the use of the private sector arising from the difficulties that I think the committee are well aware of in the Lothians. In order to reduce the backlog that the new administration and the Lothians Health Board inherited, they've had to make some greater use of the private sector than previous years. We are determined to, although it's only 0.8% of the entire budget, we are determined to bring down the future use of the private sector, particularly where the capacity already exists within the National Health Service in Scotland. In terms of nursing, let me first of all, Convener, make a distinction, and it's a very important distinction, between agency nursing and bank nursing. Agency nursing, the spend on agency nursing is now down to, I think, under £7 million a year, compared to what it was 10 years ago. It's a very substantial reduction indeed. Bank nursing averages across Scotland about 5 or 6% of nursing hours across Scotland. There are boards that have a higher ratio than that. For example, Greater Glasgow and Clyde, on the latest figures that I've seen, have a 14% use of bank nursing, and I've asked them to bring that figure down, because bank nursing has an important role to play where there is a short-term supply requirement, but it should not be a substitute for permanently filling positions in the nursing profession. And I believe that round about 5 or 6% of total nursing being bank nursing is a reasonable figure, given winter pressures, holidays in the summer, and all the other reasons why you would want bank nursing. But to have it as high, say, as 14%, I believe is far too high, and we're going to bring that figure down, particularly in Glasgow. And in terms of pressure on consultants, if you look at the number of consultants in the health service today, it's far higher than what it was 6 years ago. And in fact, specifically, if you look at one of the main pressure points, which is the 24 accident and emergency departments in Scotland, we've actually doubled the number of accident and emergency consultants in Scotland over the last 6 years. And over the last 18 months or so, there has actually been a 50% increase in A&E consultants. So I do accept the pressures. I think we're beginning to manage many of these pressures much more successfully, and have been doing now for a number of years. And the implementation, for example, of the unscheduled care plan will lead to further improvements, particularly in accident and emergency figures. But I do accept we have some way to go in some of these areas.
Can I also ask you, occasionally you pick up your newspaper and you have comments like health tourists or health tourism, people coming to Scotland or indeed the UK off a plane and immediately go to A&E. What action are we taking to reduce this or to quantify how much it is physically costing the health service in Scotland?
Well, we've looked at it, and we think this is a very, very marginal issue in Scotland. If you look at the analysis of health tourism, it's very much focused in London and the south east of England. And in terms of the cost of the National Health Service in Scotland, we do pursue people for costs where it's appropriate to do so, and we try to recover those costs, but sometimes the cost of recovery can exceed the amount you're going to recover. But it's a totally marginal figure. I asked John if he can give you a precise figure on the latest figures, but I mean, the UK is talking of a figure of £500 million a year. That was what Jeremy Hunt, the English Health Secretary, said a couple of weeks ago. I think we're in single figures almost in Scotland, certainly very low figures compared to, we certainly are not even anywhere near £50 million, which would be 10%, because it is heavily concentrated. It should bear in mind, though, that we should be very careful when we're talking about health tourism, because people in the European Union visiting Scotland are entitled to health services per the reciprocal arrangements we have as being part of the European Union. So I'm assuming that the term health tourism means people coming here and receiving health services to which they are not entitled to receive on a free basis, and that we are pursuing them for appropriate charges. And where that happens, we do, as best we can, pursue them for charges. I don't know if John wants to add anything to that.
The overall figure is very small. It's a single digit, but the Cabinet Secretary is right. We have a counter-fraud service within Scotland, and if the situations are brought to their attention, then they, in collaboration with the UK Borders Agency, do work in tandem in terms of pursuing those cases.
Okay, thank you, Colonel.
Thanks, Richard. Cabinet Secretary, you concede and accept the pressures as identified by increased overtime, increased use of bank nurses, reversing the trend that was in place, and all of the other consultant vacancies, etc. You also tell us and have told us, and we're dealing with this in debates all of the time, about the increased demand. What does this budget do to ensure that we are meeting those demands and reducing those numbers of bank nurses and agencies and the private sector? What in this budget tells me that the Scottish Government are addressing these issues in a planned way?
Well, if you, for example, look at the figure that's allocated the Unscheduled Care Plan, which is now about to go into its second year, because we launched the Unscheduled Care Plan in January, and that was £50 million over 3 years. Now, we do know, obviously, and the committee knows, that accident and emergency is one of the major pressure points in the system. So in the budget, let me tell you a number of initiatives that the budget is going to be funding and is already funding. First of all, as I've already mentioned, a very significant increase over the last year in the number of accident and emergency consultants in the 24 A&E departments in Scotland. Secondly, a substantial increase in the number of nursing and other allied professional staff in the accident and emergency departments in Scotland. Thirdly, in dealing with the pressures that the presentations to accident and emergency put in other parts of the hospital, because the key to this is patient flow, we are investing heavily, for example, on improving the management of both the flow of patients and bed capacity management in our hospitals. For example, initially in the Borders Board area, they piloted, we're now rolling out an ward management initiative, and that will be rolled out throughout the whole of Scotland by April, May next year. We're also investing heavily in terms of improving the coordination within hospitals so that it's not managed in silos. We're also looking at a whole range of initiatives in the community to reduce the pressure, and this is all in the budget. I think. Well, it's right.
There's focus on change of delivery. Right. Where is that in the budget?
Well, it's right through the budget, actually. If you look at the territorial budgets and the above inflation increases, then those increases are going to fund these kinds of initiatives. Now, all these initiatives at this level in the budget are not highlighted as individual line items. Obviously, we budget for them below the level 3, level 4 that the committee deals with, but they're actually there as part of the calculation of the budget for each territorial board and for each of the 8 special board special boards within the health service in Scotland.
Cabinet Secretary, you've recently, in top of all these pressures that we've got now, you've recently made an announcement that we're going to have 7 days a week, 24-hour health service. What pressure will that put on the services that are already under pressure? How will that help this situation to reduce the use of the private sector, to reduce the number of bank nurses, to reduce the number of agencies? How will we manage that, and where does the budget say that we're going to manage that?
Right. Well, first of all, in terms of 24/7 working, obviously the health service, because obviously when these matters are reported in the press, there's a lot of shorthand used. So let me explain what 24/7 working is, because we already have 24/7 working in the National Health Service, and we've had it since the day it was brought into being, because emergency services, for example, are 24/7. We have out-of-hours GP services run by NHS 24. So access to GP services is 24/7. But what we are saying is, and what drove us to making the announcement we did make, is at the moment, the way in which we run our hospitals in particular is very much geared to the 5-day week. So let me give you some practical examples. A patient, maybe of a Friday evening or a Saturday morning, is ready for discharge. They cannot be discharged until a Monday, not because of the inability or the lack of a consultant or the lack of nursing, but because there's nobody in the pharmacy to dispense the drugs needed for that discharge. So an example of where we need to extend 24/7 working is to have pharmacy services available on Saturdays and Sundays to allow discharges to take place. We do know, and all the evidence clearly tells us, not just in Scotland but elsewhere, the longer somebody stays in hospital, the less chance they have of maximising their health outcome. So to keep people in hospital 2 days longer in that scenario than is necessary is not the right thing to do in terms of health outcomes. Second major issue is that we've looked at the pattern in our hospitals in terms of the flow of patients and bed management, bed capacity management, and a range of other factors in terms of what happens towards the end of each working week, 5-day week, and what happens at the beginning of each 5-day working week. And essentially, you've got a very uneven flow that is taking place. And that is resulting in some of the pressures that we're talking about being exacerbated because of that. If we manage the flow of patients, if we manage the bed capacity over a 7-day week, outside planned care, because 70% of all the patients in hospital are there on an unscheduled basis, we believe we can improve significantly the efficiency, the quality, and we can improve the health outcomes of the patients. And I'm happy to arrange a more detailed presentation on the rationale behind that argument and on the figures behind that.
I think I'm trying to pick up, Cabinet Secretary, I'm going to move on to the next question. I'm trying to pick up on what Audit Scotland said about the indications of pressure. And I think as politicians, I mean, I think we'd all want to see that, and our constituents would want to see an even service and a good quality service whenever they get into the hospital. So we're not a difference there. I think what I'm trying to highlight is what has already been highlighted by Audit Scotland. There are signs of pressure, symptoms of pressure within the system, and indeed evidence that we've had from those who deliver. I see Mr Matheson would like to.
Convener, just a follow-up on your initial comment about where there's evidence about the strategic direction that we're trying to achieve here. I think one of the problems that we have in the way that the budget's presented is it tends to focus people, understandably, on the marginal increase. So how has the budget moved compared to the previous year? So how is the additional £284 million that's going into the health budget in 14-15 been allocated? How has it been spent? Whereas we try to get a broader focus, not just on the additionality, but on the core budget. So a good example of that is the musculoskeletal services in Ayrshire and Arden, which is a redesign of an existing service and using physiotherapists to triage orthopaedic referrals. And the impact of that is a reduction in referrals to orthopaedic consultants in Ayrshire and Arden of 288 per month. and a reduction in the waiting times from 2,000 down to 1,000. So that is a redesign of an existing service, not a new investment. So I think we need to look, as well as looking at the marginal increase, we also need to look at the 98% core budget and how we're using that effectively.
Yeah. And if I could just add to what John rightly said, we're now rolling out the musculoskeletal service. For example, it's now going to be rolled out into Grampian, where one of the reasons why Grampian's waiting times have not been as good as they need to be is actually because of the number of people waiting for orthopaedic procedures in Grampian. By introducing the initiative that was started in Ayrshire and Arran, rolling it out to Grampian, it'll be rolled out to other areas as well, then we expect a similar significant impact on waiting times and waiting numbers for orthopaedic procedures in the Grampian area.
We have the budget before us, and we're interested as a committee about these things too, about the preventative strategy, the change agenda and inequalities. And in when you look at the budget, it doesn't say this is what we're doing to make that shift change. And it doesn't even look at whether, when, what we've got wrong in the past and what we need to fix. So it's not as clear in that, but I mean, I'm sure that will come out in the questions. Rhoda Grant.
The committee's been working on the Public Bodies Bill, and there is an emphasis on kind of integration of health and home care and care within the community. How can we track that through the budget? How can we track the way if the spending is moving in the right direction?
Well, I think just picking up the point that John makes, because of the level at which you're looking at the budget, level 3, level 4, much of that detail is at a lower, a more detailed level. So you would need, let me give you an example. In West Lothian, they have run an integrated health and social care system for the last 8 years. If you look at the budget at this level for NHS Lothian, that would not stick out as being the case because of the way the budget is presented as required by Parliament. But everybody in this committee knows that there's been a very successful integration in West Lothian over the last 8 years. So I think what's important is that you have to consider the budget along with the narrative in terms of what we're trying to achieve in the health service, a key point of which is quite rightly integration. And going forward, obviously one of the areas that will now, because we're putting integration on a statutory footing, is one of the areas in which the presentation of the budget will have to change in future, is to show the integrated budgets for health and social care of each one of the 32 partnerships. So I would envisage that once the bill is through and once we've implemented integration, in 2 or 3 years' time, when we present our budget to Parliament, we would actually include the information showing the budget for each of the 32 integrated partnerships, because that will make up a very, very substantial proportion of the total health and social care budget for the whole of Scotland. Now, at the moment, we don't do that because, with the exception of a few areas like West Lothian, we don't have an integrated system, and it's not on a statutory basis. But once it's on a statutory basis, I would say, convener, in future years, we would show each of those partnerships and what budgets they have, because they're going to be such an important part of the overall picture.
Would it be possible to have that information sooner? Because then you would have, I guess, a starting point in which you could make comparisons as it rolled out and as further integration took place. It would allow us to track.
Well, I think the problem is that each partnership is at a different stage of development. I mean, we're happy to provide you with where there are integrated partnerships with the information in terms of, how much does the West Lothian partnership spend, what's its budget, and how is that funded between the Health Board and the local authority. I mean, we'd be happy to help provide that kind of information. But it would be very difficult to do that until the bill is through and until we have the integrated partnerships up and running, because clearly at the moment it's done on a voluntary basis. There is wide variation between the existing voluntary partnerships and how they do account for budgets and how the budgets are reached and what services are provided by the partnership. That will be much more standardised, as it were, once we get the statutory implementation. But certainly the earliest opportunity when that information becomes available, I'm more than happy to supply it to the committee.
That would be certainly very helpful. I understand that you have integrated resource framework reports currently that show some of that spending and how it's tracked. Would you be happy to give that to the committee as well?
Absolutely. We can give you a full briefing on integrated resource funding framework.
That would be useful. And just one final point. In your statement, you were talking about the ring fence for health board budgets and how that's protected. How does that, is that a block, or how do you overcome actually moving funding from acute health into community care, which is a local government service historically? Does that become a block? Does that stop that resource moving, or does community care move into health to be part of that funding?
Essentially, there are three really important points here. First of all, as the partnerships are created, we envisage that the primary care budget of the health board will become the responsibility of the partnership. We envisage the social care, as defined in the legislation, the social care element of the local authority's budget will become the responsibility of the partnership. And in addition to that, there will be a share of the acute budget, the health board's acute budget, which will be under the direction of the partnership. They won't physically handle the money, but how that resource is used, and particularly how we transition from treating so many people for certain conditions in the acute sector into the community, that will be under the direction of the partnership.
So the budgets will stay the same. It is, and then they put. So how does it work in practice? If you see that you could use some, say, acute care funding for preventative spending in the community, there won't be a block to that by this ring fence.
Well, this is where the commissioning and where the plans of each partnership is very important, because part of their own plan will need to be how they're going to transition in each area into providing services in the community that are currently provided through the acute hospital budget, the acute health board budget. Now, the issue is, how do you get to where you want to be from where you're starting? And each partnership will have a transition plan. I mean, we've already done this. Indeed, I think it was under Mr Chisholm's period as Health Minister when we transitioned into care in the community. When obviously you started with a map across Scotland of institutions in terms of mental health institutions and other bodies, and eventually over a period and working to a plan in each area, we transferred those patients into the community. But the services have to be available in the community before the patients are transferred from the acute sector to the community sector. But it's not actually looking at it in terms of silos either, because the way in which a lot of this will work is that consultants who are providing services entirely in the hospital situation at the moment, many of them will actually be working in the community in future. And that's already happening in many parts of Scotland, even where there is not a formal integration partnership.
I think the other factor, just very briefly, if I may just highlight, is the change fund, which is £70 million in 14-15, will increase through the integration fund to £100 million in 15-16. So that is specifically designed to deliver exactly what you're describing. And scheduled care, the £50 million over 3 years, again, would be used for investment in primary care in terms of preventative anticipatory care. And in 15-16, there's also a central pot of money, £20 million, looking at developing hospital-at-home services, developing telehealth, telecare. So there's a number of specific pots of money. I'm arguing against myself in terms of trying to look at the totality of the budget, but there is also specific pots of money set up to deliver exactly the change you're describing.
Yes. I suppose my concern is, at the moment, what's really happening out there is that local government budgets are being cut. Home care is being cut, which then leaves vulnerable people without receiving the care that they should. That then has a knock-on impact on them, that they become unwell, that they're not eating properly, that they're not being looked after properly, they're maybe not taking their medication properly. And then they become a health problem rather than a social care problem, because their health deteriorates, and many of them are going in through A&E because they reach a crisis point. I suppose my real worry is that is social care, that is a local government responsibility. And if we only have the money that is currently available in local government budgets to still fund that part of the integrated system, then we're not really going to make an impact on that kind of preventative spend that will stop people actually moving into health. So unless we get some of the health budget out into that area that actually is a preventative spend for health, I don't think we make a real difference.
Let me give you a practical example, which I think I've quoted to the committee before, and this is the kind of way to approach this. The pilot project being run down in Dalmellington in East Ayrshire, jointly between the local authority and the health board. It's a pilot project of 20 older people, all with comorbidities. And basically, that is a run through the GP, the local GP service, but obviously with all the agencies involved. And they're looking at the total needs of these 20 people, both in terms of their healthcare needs and their social care needs. And what they've done is, and through the use of telehealth technology, over a period of the first 18 months of the pilot, they reduced the level of hospitalisation amongst these 20 people by 70%. And that's a small example of how we need to do this in the future. That rather than think in terms of, this budget from local authority, that budget from the health board, once the partnership has their budget, they then need to look at where the priorities are to achieve the national outcomes that they will be charged with achieving. And it's the kind of pilot that we've seen in Dalmellington. There are many others I could quote that will achieve that. And actually, that is much more cost effective, because what effectively that is doing, although it would be difficult to find that out from a budget statement, what that's doing is transferring resources into the community, because it costs £4,600 a week to keep someone in an acute hospital sector. This telehealth service is costing a maximum of £900 a week. So the money, you're saving a lot of money by keeping people out of hospital, and that's freeing up the resource to expand that service once it's rolled out.
Malcolm Chisholm, followed by Nanette Millen.
Right, if I can just pick up some points you made there before I asked what I was going to ask. I'm just trying to work out what Mr Matheson said about integration. So, I mean, as I understand it, the change fund's coming to an end in 14-15, and I can see an integration fund for 10 million, but is there another line somewhere in level 4 figures about integration? Is that just the change funds in another form?
I'll explain the general, and then I'll let John explain the detail. John Swinney, in his budget statement, announced a £120 million to help integration. £100 million of that's an integration fund, and there's another 20 million that we've identified. For example, we announced last week that half of that money, the 10 out of the 20 million, will be used to help roll out the Dalmellington project. Okay? The other 100 million, Michael Matheson has been charged, along with officials, in consultation with all the key stakeholders, to design that fund, the criteria and so on. And the purpose of that is to address the kind of issues that Rhoda mentioned in transitioning people from care in the acute sector to care in the community. And that will become available. That fund will become available in 2015-16.
You're examining the current budget. Is it somewhere in the current budget line?
No, it's 2015-16, that 100 million.
Is the information available? Is this additional information that you're giving us now, or is it in the level?
No, John Swinney announced 100 million in his statement.
Part of the draft budget, it's in the draft budget book.
Is that just the change fund in another form? Because the change fund's coming to an end, presumably, before that. Is that right?
No, it's specifically about integration.
It's specifically to deliver the health and social care integration. That's where its specific focus is. So we're giving £100 million out to individual health boards and £20 million to try and take forward initiatives at scale on a national basis. So that's the...
Okay, well, I'm sure we'll look further at it. I mean, I mainly wanted to ask you about, the linking of indicators and outcomes with financial decisions. But before I do that, can I just raise 2 points that Audit Scotland have raised with us? Firstly, they're saying, and it's in the report obviously, that it would be helpful if boards could be given a break-even period of 3 years rather than 1 year, because they think that causes a lot of problems for boards having to break even every year. And secondly, they've highlighted a problem with some of the ring-fence money that goes to health boards not going at the appropriate time, and that's creating problems for health boards as well. I mean, you must have seen their report. I wondered if you've got any comments on those.
Again, I'll get John to give you the detail, but on the first point, Malcolm, what we are doing is we are in discussions with John Swinney and his team to have a similar arrangement that local authorities have got, whereby they're able to get, in terms of end-year flexibility, they're able effectively to not lose the money. If they haven't spent all their money, they can basically build up a reserve. I mean, I think John told me this morning, I think it was a reserve of about 36 million in Orkney, for example, that's been built up. So it's about what the Treasury call, I think it's the exchange... Budget exchange mechanism. The budget exchange mechanism. And we asked John to explain how that would work, and how, if we can get agreement that the health service would have access to the budget exchange mechanism, how that would help some of those issues identified in the Audit Scotland report. John.
There are two questions there. I'll pick up on that one, then I'll move on to the issue about allocations. So the budget exchange mechanism, that we are very clear and very focused that we need to achieve our financial targets, and our financial targets regime is set in terms of delivering financial targets on an annual basis. But we're also extremely clear that we need to be doing medium and long-term planning as well. And that's why the financial plans that come in from boards are normally 3 to 5 years in terms of duration, and we sign them off on that basis. There are certain boards where we have a particular focus on where the plans are signed off on an annual basis, because we're looking for reassurance around the delivery of financial balance going forward. So the delivery of a financial break-even every year is something that's not helpful in terms of medium to long-term financial planning. So having some flexibility across the year end, as you're suggesting, would be very welcome. And local authorities have that ability. The overall Scottish Government, through the budget exchange mechanism, has that flexibility. So we're looking for the health component of the Scottish budget to be given some flexibility. It wouldn't be significant in terms of scale, but it would allow the management of the in-year financial targets to be achieved in a way that didn't disrupt the medium long-term planning in terms of that. The second point around the allocations, we've tried to do two things in terms of allocations to health boards. We've tried to reduce the number of specific ring-fenced allocations, and particularly driven around inputs. So we've tried to move on to more of an outcome and an output basis, and we've tried to bundle allocations around themes. So rather than giving a specific allocation around alcohol brief interventions, we've maybe given a more generic, we have given a more generic allocation around primary care initiatives. And the totality of that bundle is, say, just over £200 million that goes out to health boards and goes out early to health boards. Where we can, we give the allocations out to health boards as early as possible in the financial year, and the vast majority of allocations have gone out to boards in the first 3-4 months of the year. Sometimes we do keep some monies back to specifically deal with the issues that happen in the year, perhaps a particular focus on the delivery of waiting times and some specific allocations in respect of that. There's sometimes some technical accounting allocations that are given out towards the end of the year, but in terms of boards' allocations, they will get 96-97% of their allocation in the first 4 or 5 months of the year.
So if I could just move on, finally, Convener, to my main question, really. I mean, the Finance Committee is particularly focused in its budget scrutiny and has reported this to committees on trying to link up some of the indicators and objectives with the financial allocations. Now, I suppose one of the problems in health is that there seems to be a proliferation of indicators and outcomes, and we've got new outcomes coming with the joint working bill. So it would be interesting for your views on that point and how they kind of all relate to each other. But I suppose the more substantive question is, can we have, I mean, the convener's already raised this in relation to prevention and inequalities, can we have more linking up of these overall outcomes, objectives, indicators with the actual financial allocations? So, you know, for example, could the budget be linked to heat targets would be one issue. I mean, the convener's already said, can it be linked more to prevention and inequalities, which are two overarching objectives, because certainly, that, as I say, that's one of the things that the Finance Committee is very much asking committees to focus on this year.
Well, already there is quite a linkage there. If you look at the NRAC formula, which obviously it looks at, for example, the degree of remoteness and rurality as a contributing factor to deciding which health boards get what kind of funding. It also looks at the profile of the population in the area to look at who should get more funding. So that's a very good example of where the funding formula for particularly the territorial boards is very much related to the challenges that they face in their community and to the socio-economic profile of their community. And the NRAC formula is very much designed to do that. In terms of specifically relating to targets, and I think you really raised, Malcolm, 2 points. Number one, do we have too many targets? And number two, how do they relate to the budget? We've actually had downward pressure on the number of heat targets in recent years, and we are now down to basically 16 heat targets. My own view is there is further scope for further reduction in the number of heat targets, and I would like to see the heat targets even more totally directed towards outcomes rather than, for example, throughput. For example, a heat target in relation to alcohol is the number of consultations on alcohol. That's a throughput target rather than an outcome target, and it's one of the ones I'm keen to look at to see if we can get a more appropriate outcome target. Indeed, if we should have a target at all rather than a throughput target. So on the first point, I'm totally with you. I do think there is scope for further streamlining of the number of targets that we have, because clearly, you know, the more targets you have, the less, ironically, the less management control very often you have over what's actually happening in terms of budget and indeed the wider operation. On the second point, in terms of achieving a clearer linkage between targets and the budget, very clearly each board is charged with achieving their share of the national outcomes in terms of heat targets, for example, and other national outcomes. But there's also performance targets, for example, in relation to the management of their estate, or we have a target in relation to the prompt payment to companies, which is part of a government target, and so on and so forth. And all of these do relate into the budget, but of course they do so collectively rather than each individual target you know, being a line item in the budget. I think that would be impossible to manage if you did that.
Okay, can I just have one more question in case I don't get in again? Just two budget lines that I wanted to ask questions about. I mean, one's been highlighted before, but you know, the big drop in the Clean Hospitals line. So I think we should certainly want to know what the reason for that is. A smaller reduction in the research line. I'm told there's a particular downgrading of primary care research, which seems to be a bit inconsistent with what you said about the increasing importance of primary care. So.
We'll deal with the reduction in the line item regarding hospital infections and so on from 28 million to roughly 18 million. This is not a reduction in expenditure. What has happened is basically much of the work that previously we had to pump prime is now part of the mainstream work of the hospitals, and as you've committees aware, we've seen a very, very substantial reduction in health-acquired infections in recent years, so much so Professor Don Berwick has now said that through the Patient Safety Programme, the Scottish Health Service is probably the safest in the world. So that's not a reduction of 10 million. It just means simply we no longer need that 10 million for pump priming because it's already now day-to-day business. It's part of the day-to-day business of every health board delivering on these issues. As far as research is concerned, a number of points. First of all, we are using a research budget in different ways, and all the research we're doing is not actually contained in the research budget, because some of it is contained. For example, if you look at the Glasgow Southern General Hospital project, where as part of the new project there is going to be a new learning and education centre which will be carrying out some research and development. That's in the Glasgow budget as opposed to itemised in the R&D budget. Secondly, we are have adopted a very proactive strategy of using our own research and development resources to leverage in additional R&D resources from elsewhere. For example, John has been very successful in negotiations with the European Union in using our R&D spend to leverage in additional spend from the European Union. And thirdly, some of this also appears in the capital programme. For example, we've already announced that, well, yesterday we opened officially, we launched the Digital Health Institute. Now, that's all about research and development, but the capital cost of doing that is in the capital budget as opposed to double counted into the R&D budget. So if you added up everything we're doing in terms of research and development, we're doing much, much more than that particular line item suggests.
Gabe, welcome. And Nanette Millen, followed by Bob Doris.
I confess I have a brain that functions more medically than financially. And I do actually find it quite difficult to reconcile forward planning, the interesting things you've been telling us this morning, with the sort of budget lines on an annual budget. But I'm particularly interested in the forward planning, and particularly in terms of workforce planning, because I do have a serious concern about it. Now, I know you have mentioned A&E and the increasing number of consultants in there. You've also spoken about the orthopaedics and the different way of looking at things. I have to say, in relation to Grampian and orthopaedics, the 7-day operating, with pharmacy working at the weekends, does actually work, certainly in one orthopaedic unit, where patients are routinely discharged on Saturday or Sunday with help from the pharmacy, following hip replacements and things. I've been there, I've had that experience myself, and that does happen routinely. But, I mean, the Audit Scotland report nonetheless says there's been a 21% increase in consultant vacancies between 2012 and 2013. Now, I presume that's across the board. I know in Grampian, particularly, we have, I'm not sure about A&E, but we had orthopaedic difficulties. There's difficulties in paediatric rheumatology, ophthalmology, psychiatry, psychology, in recruiting consultant staff. And I just worry about how this is going forward. What assessment has been made, not just in Grampian, obviously, but across the board, about the need for medical staff over the coming, say, decade, and also when you're looking at different ways of working, the sort of professional mix, how much consideration has been taken in consideration of that, and how does that tie in with this budget and budgets in future?
Well, can I say the professional mix is as important as the raw numbers. So when we are doing our workforce planning, we look at the professional mix required as much as we look at the overall numbers, because the two are very important. There's no point in having a surplus of consultants in A&E when some of that resource should be in orthopaedics, for example, or in ophthalmic or whatever. So the mix is as important as the raw numbers, point number one. Point number two is in terms of the vacancies issue reported by Audit Scotland. When you're increasing the overall number of consultants, and particularly increasing them so dramatically, for example, the 50% increase in A&E consultants over a very short space of time, inevitably there will be a period when you then have a rise in the number of vacancies. The rise in the number of vacancies is a factor, to some extent, of the rise in the number of jobs. And therefore, it's good news rather than bad news. However, having said that, there is undoubtedly in some key areas, for example, paediatrics is a good example, where there is an overall shortage, not just in Scotland, but indeed throughout the UK and indeed wider afield, in terms of the availability of paediatric consultants. And we have been doing, for example, in St John's in Livingston, we spent an additional £100,000 in advertising 4 paediatric consultant appointments, which are now being filled, 2 of them by people from Burma, Myanmar, which is very welcome. We were able to recruit them. So we're filling those vacancies, but I wouldn't like to give you the impression that many of these vacancies are easy to fill, because in these areas where there's a shortage, sometimes a worldwide shortage, of these particular skills, then we do have to spend a lot of additional money, as in the case of St John's, in order to recruit these consultants. The third point I would make is, in terms of workforce planning, we've already published our Workforce 2020 plan, and that is a very detailed plan, both in terms of the numbers of people we need as well as the mix. And you've seen the increase in the overall number of staffing, and particularly qualified nursing staff, over the last year, which is a very welcome development. But in addition to that, we are, and some of this is done with our colleagues south of the border. We are involved, for example, with Sir David Carter in his role as chair of the academic board. We're involved with the Funding Council and my colleague Mike Russell on education and lifelong learning, looking at the supply in future of medical trainees. And as you know, we've halted the reduction in the number of trainees this year, and we are actually looking at whether we need to further increase the number of trainees next year and beyond. And Sir David Carter and others are actively working on those issues. So we have to look at this as a pipeline, you know, of people going into medical school, the dropout from medical school, right through then to the point of qualification, and then from qualification, the numbers who specialise in different areas, the numbers who want to be GPs, the numbers who want to be A&E consultants, and so on and so forth. So at every stage of all of that, we have a very, I think, detailed understanding and knowledge of where we are both in the current situation, but going forward, what is likely to happen, and we can identify where we're likely to have future shortages, and where we see that, then we take appropriate action to try and, you know, if it's a long-term shortage, work with Sir David Carter and his team, for example, to increase the number of trainees, or if it's a more short-term one, increase the spend on advertising to fill the vacancies. I also personally get a report every month on all vacancies, no matter for what particular position, all vacancies that have been vacant for more than 3 months. And then my team then follow up to find out why any vacancy has been vacant for more than 3 months. And we then, if necessary, offer our support to the relevant board to try to fill any vacancy that's been vacant for over 3 months.
For that, I realise it takes a long time. The pipeline is quite long between sort of planning and actually getting the trained staff in. But I mean, I've been around long enough to see this happen. You know, having too many doctors, then too few, and so on. But given the sort of planning you say is going on, does that mean that in future we should not be looking at what has happened? I'm not sure what the current situation is, but it did happen very recently, was that we had trained nurses unable to get jobs. We trained AHPs, physiotherapists, occupational therapists, unable to get jobs simply because the funding was not there to provide the jobs for them. Is that being taken into account in forward planning, and can we look at that not being an issue?
Well, we obviously have to plan according to the needs of the service, rather than, you know, to deal with any particular surplus or whatever. But basically, there is no strategic shortage of nursing jobs. In fact, as you know, the number of jobs and the number of positions in nursing has increased quite significantly in the last 12 months or so.
I'm interested a bit in this as well. I think about the current needs versus future needs and the overall strategy of getting people out of hospitals. Meanwhile, we've got a 2020 vision that looks at stuffing the hospitals with more doctors, nurses, and, you know, it seems to be a contradiction there for me. But I'm sure there is a reason for it. And recent figures that this committee looked at, I think we saw in those figures an expected downturn. So it was planned for the reduction of nurses. But in the other columns, I think we saw an anticipated rise in health professionals of a wider nature, and that was perfectly logical to me. But I think it goes to the heart of Nanette's problem. A couple of years ago, we were planning to reduce the number of nurses and beds in hospitals, etc., etc. Now, within 18 months, we've got a recruitment drive to get nurses and doctors up. This is no way to run a railway, is it?
Let me say, in some board areas, both in terms of their forecast on nursing requirements and their forecast on the number of beds required, some boards related to one and not the other, some related to both, but over the piece, there were some boards who were over-optimistic in terms of the number of nurses they would need. Now, let me take the example of Lanarkshire. Lanarkshire, in my view, was over-optimistic in terms of the overall reduction in the number of nurses it planned for to meet the demands of the NHS in Lanarkshire. The NHS board in Lanarkshire has recognised that, and for the last 9 months has been recruiting nurses to make sure that it gets up to the level where it needs to be. And I think that forecasting is very, very difficult. If you look at the situation in Edinburgh, the main strategic issue in Edinburgh is that when Malcolm and his predecessors and successors were planning the new Edinburgh Royal Infirmary, the forecast they had for the population of Edinburgh has turned out to be wrong by a factor of 20%. It was too optimistic. The population of Edinburgh is 20% higher than was forecast at the time when the ERI was being planned. So, as Dennis Healy, I think, famously said about forecasters, you might as well talk to the Boston Strangler than rely on economic forecasts for informing policy. And the health service, obviously, forecasting is not an exact science. Situations change. I remember when we came into this Parliament, the big issue was depopulation in Scotland, with the Registrar General then forecasting that by 2030, the population of Scotland would reduce to under 5 million. Here we are sitting today and the population of Scotland is at a record level and rising. The Registrar General's forecast was nonsense. Now, at that time, you couldn't tell it was nonsense. Life changes. And, forecasting is not an exact science in the health service any more than it is anywhere else.
No, but I would like to think, Cabinet Secretary, you give the committee more confidence in your overall radical strategy to radically change the delivery of health services from the hospital settings into the community, and the budget and the ambition and the workforce planning that is going to describe a new workforce. That needs to be, if this is going to happen in 3 years, who's going to deliver? What plans are in place? What workforce is going to deliver that new radical strategy out of the hospital, in the home, where everybody wants to be?
Can I just pick up what you said, because it's in direct response to that question, Convener, when you said you found it difficult to reconcile, on the one hand, as saying to reduce the level of hospitalisation, and at the same time, plan for an increase in the number of hospital consultants, for example. The answer to that is really twofold. Number one, even although there will be more healthcare delivered in the community, a lot more of it will be delivered by these consultants who currently do not work in the community to a great extent. So if you look at, for example, in the southwest of Glasgow, where there has been a major initiative on treating far more patients with COPD in the community than had been the case before, a very successful initiative, part of doing that was the consultants to come out to work part of the time in the community, which previous to this pilot had not happened. So we shouldn't, this is where thinking in silos is very mistaken. We need the consultants in relevant cases to work in the community along with the GPs. It's not a case of consultants being confined to the hospital. If you look at one of the successes of the integration in West Lothian, one of the reasons why it's been so successful, particularly in recent times, is there is much more involvement of the hospital consultants in the provision and delivery of services in the community. And that's extremely important. And that's why that apparent contradiction isn't a contradiction. It's part and parcel of our plan.
House calls
Well, working in the community, yes, and in West Lothian, they do go to people's houses and do some consultancy work there, yes.
Yes, I think on this point I've got Rhoda, but I'll take Dennis in because Dennis hasn't had an opportunity to speak. On this point, Dennis?
Yeah, thank you very much.
Thanks.
Thank you, Convener. Good morning, Cabinet Secretary. Do you envisage some degree of flexibility then from acute services across the board, you know, including consultants, nurses, etc., going into the community? So it's like a secondment. And if so, do we actually have the community facilities there in terms of the logistics for that to happen? And then obviously, if the capacity is to go back to the hospitals, then people are going back into the hospitals. Do you envisage that sort of degree of flexibility?
Can I say, I've just actually come this morning from a major telehealth conference. And I mentioned the Dalmellington project, Dennis. Actually, what's happening more and more is that the consultants are working with patients in the community, but they're using, for example, new technology like telehealth. Let me give you an example. I visited Inverness a few months ago, and I was visiting the mental health services in Inverness. And what they've done there is they've started to transform how they deliver consultant mental health services in the community. For example, I saw and sat in on a consultation of a dementia patient in a nursing home 50 miles from Inverness. Now, before the telehealth technology was being used, these dementia patients were being forced for a consultation with the consultant to travel a 100-mile round journey, which for a dementia patient is absolutely the last thing they should be having to do. So even in the face of the then scepticism of the consultant, we were able to persuade her to introduce the telehealth service. She's now the biggest proponent of it because from her base in Inverness, she is able to consult regularly, much more regularly, with these dementia patients in a nursing home 50 miles away with their carers. So that's an example of consultants working in the community in a way that was never possible before. Now, it may be from time to time they physically will do house calls, but I think they're much more. I think they're much more likely to do it through telehealth necessarily than through house calls. But that's a very, very good example of a consultancy service being provided directly in the community rather than forcing the patient to come and visit hospital.
Yeah, but that's on the point of sort of consultants, etc. But right across the board, if you take your nurses, etc., and if you're saying in some places there might be overcapacity within the acute sector and the hospital, do you envisage that there would be some degree of secondment into the community to maybe, you know, for instance, maybe the family nurse partnerships or health visitors or whatever, and then, you know, a reverse trend happening in terms of if you need them back in the acute service? Do you envisage a flexibility of working across the board in that sense?
I'm going to bring in John in this in a minute, but just before I do, can I just say, Dennis, I'm not saying there is overcapacity in the hospitals. What I'm saying is, moving forward, we're all going to have to work in a different way, and we're going to have to use, for example,
in terms of early discharge, so therefore there should be less bed capacity maybe in the future because more people in the community. So therefore you need to be able to provide the nursing care as well as other care facilities within the community.
Yes, but the problem with the capacity issue is while people are getting turned around a lot quicker in hospital, the nature and the complexity of the cases that now people are seeing compared to even 10 or 20 years ago is much greater. And I think one of the major pressures, when you hear the RCN, for example, talk about the pressures in certain areas, when you actually ask them what do you think is causing that pressure, very often it's now about the complexity of the patients they're seeing compared to 10, 20 years ago. So I don't want to give the impression that there is a lot of spare capacity in the acute sector. What I'm saying is that to face up to the challenges of an ageing population, the challenge of an increasing population, the challenge of reducing inequalities and the financial challenges, we need to work differently in the future, and that includes how hospital consultants, for example, work as well. Many of them are already doing it and actually doing it very successfully. I'm going to ask John to come in with some supplementary comments.
He'll just remind the Cabinet Secretary's position. Committee, please come in. Could you tell us as well about the scope of the IT budget and the telehealth budget, whether that's gone up, down, or whether there's significant investment there or not, or staying the same even?
Delighted to do that, but I'll start with that point, Convener. Cabinet Secretary mentioned the European Telemedicine Conference that's taking place in Edinburgh over the next couple of days. We've got 400 delegates there from not just Europe, but from the United States, from Korea, from Hong Kong, from across the world, who've come to learn from what we're doing in Scotland, but also to share some of their experiences and some of the stuff that we're doing. We've got a very high profile from a European perspective in terms of some of the work that we're doing. At the Reference Site Awards at the beginning of July, we had 2 3-star awards coming to Scotland. We were one of the 3 regions in Europe who actually got 2 3-star awards. And one of them was for the Scottish Patients at Risk of Readmission and Admission programme, which is operated through the Long-Term Collaborative. And that is looking at how we use technology to identify patients who are potentially at risk of readmission and prevent that happening through some upstream work, through the use of technology. Your specific point about investment, we've been successful in gaining a significant amount of European money coming in to support some of our investment. So it's not just what we're putting in through the budget, it's supported through the European initiatives. We are involved very actively in looking at how we can increase the health of the Scottish population by 2 years over the next 4 or 5 years in terms of a healthy life expectancy alongside the European initiative. A couple of further points. One, just for absolute clarity, the workforce vision, the 2020 vision, is driven by our overall quality strategy, is driven by our route map in terms of our 2020 vision. So that's what drives us. Another specific point on technology is the use of mobile technology to enable our community staff to work more effectively and more productively. I've previously spoken to the committee about DigiPens in the Western Isles, but smartphones and iPads are other very specific examples of that. My final point would be around, I spoke earlier about the risk of focusing on the margin in terms of the budget and not the totality of the budget. And yes, we can have a detailed conversation and constructive conversation around the vacancies, whether vacancies are rising or falling. But we also need to look at the totality of our workforce and how we use in a more productive way some of the untapped skill mix that we have, skill mix potential. I spoke earlier about the MSK project in Ayrshire and Arran, where physiotherapists are having a more proactive role. Some parts of Scotland just now we've got consultant podiatrists, so chiropodists, who are now doing a minor orthopaedic work in terms of bunion removal, etc. And that's allowing orthopaedic consultants to use their expertise at the more intensive end. And that has got the support of orthopaedic consultants in terms of taking forward that initiative. So skill mix and how we use our existing workforce and use the skill set that they have is one of the other challenges that we're progressing forward. But the telehealth, telemedicine agenda is one where Scotland has a very high profile. In Europe, the Digital Health Institute that Cabinet Secretary mentioned has been done in partnership with some of the major worldwide players, such as Samsung and Philips.
I hope you notice, Convener, that we're extending your lifespan by another 2 years over the next 3 or 4 years.
I'm very appreciative of it. I'm very appreciative. And if I wait 2 years, I might get... Is the budget line in IT and telehealth up or down in the current budget?
The budget line in the IT e-health is flat. Sorry, is flat.
Right.
But the European investment will mean that overall it's increasing.
By how much?
I don't know the precise. I can give you precise figures.
Rhoda, it was on this future planning just...
Yeah, and there was a point made to us, I think, by the RCN and Unison when they give us evidence. They were talking about the cut in training for nursing, midwifery and AHPs, and they were making the point that if you're going to shift and have people working differently, you therefore need to train them to work differently to make that efficient, using e-health and working in the community as well as in the acute sector. And they were kind of saying this cut in budget doesn't really add up to the change that they have to do in the training for that change.
We saw that evidence. We don't see where they're getting a cut in the training budget for nurses, quite frankly.
Let me see, I've got it in front of me, table 3.03, detailed spending level 3, and it's the education and training And there's workforce, which goes from 31.1 to 30 to 33 over the 3 years. Nursing, midwifery and allied health professionals, 148.9 to 137.8 to 135.8.
Well, that's just a small part of the overall budget in terms of training. I mean, if you look at the overall budget that we're spending on training of nurses and so on, you know, in terms of you take into CPD and a whole range of other things, we think we're actually probably spending more, but I'll ask John to specifically comment on that table.
I think the specific reason for that reduction is that we were supporting centrally the employment of interns in terms of one-year job guarantee. And going forward, that responsibility has now been picked up by the individual health boards. So there was a non-recurring increase to recognise the central support of those interns, one-year job guarantee. And health boards from going forward will now be picking that up directly.
But just to emphasise, overall, we're not spending less on the training of nurses and midwives, and we think they've misread the overall budget.
It would be helpful maybe just to get, you know, a breakdown of where
yes,
that training is happening and where those costs are.
For us, in terms of the previous evidence,
yes,
I appreciate some clarity in that. Bob Doris.
Thanks, Convener. Good morning, Cabinet Secretary and Mr Matheson. It seems a while since we spoke about the Boston Strangler, but I am going to return to him, unfortunately. Just briefly, we spoke about workforce planning, and Ms Grant was talking about workforce training. None of the committee members nor yourselves mentioned the workforce workload management tool, which I believe is currently been developed, and I think there might also be a bed management tool being developed as well. The Cabinet Secretary had mentioned NHS Lanarkshire being overly optimistic in how much they could downsize nurses in an acute setting, and now they've had to revise that. I'm just wondering, before I go into my more substantive questions, Cabinet Secretary, if you give a little bit more information in relation to the workforce workload management tool and how that can be shared across health boards to make sure that, whilst it's not an exact science, we move as far away from the Boston Strangler as possible, if you like.
Well, it's actually not just about sharing. We've actually, from the 1st of April, made it, the 1st of April this year, 2013, made it compulsory for every board to use the work tool, and we will be making the bed capacity planning tool compulsory as well. That's in development at the moment, but we hope to have that done in the next 18 months or so. So the tool is actually now compulsory for health boards, and I think it's generally regarded as a very robust tool. Obviously, we've piloted it before making it compulsory for every health board, and it covers both the mix of skills as well as the overall numbers in each of the relevant professions. And it's one of the reasons why I think already we're seeing some changes. I've mentioned Lanarkshire as a very good example, but there are many other boards where the tool is obviously informing them of their HR strategy in terms of recruitment, in terms of training, in terms of the mix of skills going forward.
And can I just check that unions and workers' representatives would have been part of the development of that?
Absolutely. In fact, it's all part and parcel of the wider strategy for the Workforce 2020, and as part of the development of that, we actually consulted with 10,000 individual employees of the National Health Service.
Thank you. That's helpful. So we are here, of course, for budget scrutiny this morning. We look at a cash increase to NHS boards of around 270 million in the coming financial year. We look at an almost 3% increase in their budget and a real terms increase with that. Now, of course, there's always demands on the NHS, and you can always spend more money if there was more money available. One of the things we asked other witnesses during budget scrutiny is, where would you spend more money, but more importantly, where would you take it from elsewhere within the health and sport budget, given that is the task before this committee within budget scrutiny? I can't recall anyone particularly volunteering where they would take money from. Have any representations been made to yourself, Cabinet Secretaries, how they would, about how you should reprofile the budget before us?
I get loads of representations about spending more, but I've had no representations during my first 14 months in the job about where I should cut.
Okay, I thought that might be quite important to put on the record. I would like to look at a theme that's come up time and again about service redesign and about preventative spend and where that's contained within the budget. I would like to look specifically at the Change Fund for Older People, which I understand in a 3-year period is around £300 million, a substantial piece of cash. of course, what I'm really keen to see is not just about how that money promotes service redesign or preventative spend and restructuring of services, but how it then gets embedded into the mainstream budget. And I think it was in relation to hospital-acquired infections. You mentioned that one of the reasons that budget line had fallen was because some of the work that had been done there has now been put into the mainstream budget. There's no need for an individual budget line for that. And the tracking of this budget this year or next year, when can we expect to see been able to identify where change fund monies have promoted service redesign? You have given some examples of that, Cabinet Secretary, but where can we pick up that's now been funded by the core territorial health board budgets? So the transition from annual funding to promote change into the core budget service redesign. How can we track that through the budget spend?
Well, obviously the change funds are still in operation and don't get completed for another 18 months or so. So at the end of that, we'll be undertaking a very detailed evaluation, including where the programme is being mainstreamed into a particular board area and whether that's then being rolled out across the rest of the country. So all of that will be done as a one-off exercise, as it were, rather than do it in bits and pieces, because obviously there's loads of different projects going on right across the Change Fund funding, and we want to look at all of those and then look at the totality of the impact of the Change Fund and what difference it's made. There'll be some projects that will not be mainstream because they perhaps haven't been as successful as what had been anticipated. So in terms of the Change Fund, I know there have some particular projects have had individual evaluations, but we will be carrying out an evaluation and we will be publishing a plan, as it were, in what is transitioning from Change Fund into mainstream funding, either in individual boards or across the board. And of course, the integration fund, the £100 million we talked about earlier with Malcolm, that one of the jobs that that can do is where there has been a successful project that should be mainstreamed, then that can help with the funding of the mainstreaming and the rolling out of successful change fund projects across the system. Can I also deal generally with the issue of prevention, because prevention is right through this budget. But again, it's one of these areas, you know, you can't just take a line item and put everything that's prevention and then double count it elsewhere. Let me give you a very good example. In the budget, there's a very substantial planned increase in the amount of money we're going to be spending on immunisation. Now, this is primarily childhood flu immunisation, but it's also, for example, introduction and expansion of the shingles vaccination programme. Now, I would argue that every penny of that immunisation programme is about prevention. That's what immunisation is about. It's about prevention. So although it's not labelled in the budget as prevention, it's labelled as immunisation, but it's a very good example of where, although it's got a slightly different label, it's nevertheless about prevention. So, you know, again, this comes back to the general issue of how you relate the budget to the overall strategy and the narrative.
I'll probably want to come back to that in a second, because I was going to ask about health inequalities, and I think there's a connection there. But I suppose, just to stick with the Change Fund, I can't remember if it was 70 million or 80 million in the last financial year the Change Fund for older people was, but it's a significant amount of cash. And this current budget we see before us, health boards are getting £9.4 billion. When we get health boards in front of us, should we be able to say, well, here you had your share of £80 million last year for the Change Fund, how much of that this year have you put into your mainstream core budget? Would that be a reasonable thing to ask?
A reasonable question to ask, absolutely. Right. You know, in terms of what they're planning to do. I mean, some of them may have mainstreamed some of the projects, but they may be planning to mainstream them next year. It'll depend what stage the project is at and whether it's been properly evaluated and whether the board has taken a decision to mainstream. But personally, a legitimate question.
But you would understand our frustrations in terms of trying to follow the public pound through the health service to make sure we're getting best value for money and the money spent appropriately.
Day and daily, and I can fully understand the frustration.
All right. Okay, I'll wait with interest to hear what the health board say when we get them in front of us. Again, I was going to ask about health improvement, health inequalities budget, which is marginally down in the coming financial year, although I do see it's planned to increase again in 2015-16. I was going to ask whether that budget line actually accurately reflects the health inequalities agenda of the Scottish Government, and it actually was interesting when you mentioned the immunisation programme. Do certain immunisation programmes address health inequalities as well? Are some parts of our communities more likely to befall certain conditions and diseases and afflictions than others? And does things such as the immunisation programme help address such health inequalities? In other words, across the budget, could there be a clearer quantification in relation to what the Scottish Government is actually doing in relation to health inequalities? Because if I look at the raw data in front of us, it looks as if the Scottish Government has marginally prioritised that less than, say, the previous financial year.
I think it's another example of where essentially that line item is about pump priming individual initiatives. But, for example, I referred earlier to the formula for allocating budgets between territorial boards, the NRAC formula, which takes into account the profile of the area, including things like rurality and remoteness, as well as the socio-economic profile of the area. So I would say the way in which we allocate the funds between boards, between territorial boards, is in itself probably the single biggest health service contributing factor to trying to reduce inequality. Also, many of the policies that we have, which are not actually big budgetary items, are designed to reduce inequality. For example, the tobacco strategy is about reducing inequality, because there is no doubt that the damage that tobacco is doing amongst the poorer sections of the population is proportionally much greater than it's doing amongst richer sections of the population, for the simple fact that there is a clear correlation between levels of income and the amount people smoke. And the same with drink, with alcohol. So our alcohol strategy is also about reducing inequality, because again there is very clear evidence that particularly the use of cheap drinks like cheap cider and cheap vodka and cheap gin, which do the most damage to health as opposed to a deluxe whisky taken occasionally, clearly the incidence of drinking cheap wine, cheap cider, cheap vodka, cheap gin is much, much greater amongst the poorer people, poorer communities, because, you know, that's the fact of life. The evidence is there. So the alcohol strategy is not a big spending item compared to many of the things that you've already mentioned. The tobacco strategy is not a big spending item, but they're both absolutely critically important. And if we get minimum unit pricing, and I'm off this afternoon to Estonia at the invitation of the Estonian government to speak about minimum unit pricing, and you probably noticed the Irish government last week announced that they're going to follow our example on minimum unit pricing. Minimum unit pricing would be the single biggest contributor to reducing inequality and damage to health amongst poorer people living in deprived areas.
You know, I would agree with those comments, Cabinet Secretary. It's worth noting there was a glimmer of hope in the convener's eyes when you mentioned deluxe malt whisky during that answer there. One final question in relation again to health inequalities, and that's the funding of for GPs in each health board area. Now, you've said that, you know, deprivation and health inequality are taken into account in relation to the core funding for health boards. What direction is there from the Scottish Government in relation to health boards when health boards then decide to how they prioritise the deployment of GPs? And I know they're private contractors, but how they prioritise the deployment of GPs across their health board area? Because, as you know, a 10-minute consultation with a GP in, say, Bearsden, thankfully may have more time to spend on health promotion measures because there's less morbidities presenting in front of the GP. But in areas such as, say, Springburn, there's less time to do that. Now, right across Scotland, how much say does the Scottish Government have when that money gets put down to health board level to direct it towards areas that are most in need?
Let me give you a two-pronged reply to that. First of all, we issue and agree with a local delivery plan for each health board, including the special boards. There has to be a delivery plan in each health board. So we don't just give them the budget and say, get on with it. We give them the budget and say, this is what you've got to deliver. So whether it's investing more in primary care, whether it's solving problems of GP shortages or whatever the issue is, the local delivery plan for each health board will reflect what we want the health board to do in particularly the year ahead, although we look also at, we take a 5-year horizon in our discussions with health boards, obviously. And that would be the main way in which we would overall influence decisions by the health board. But secondly, obviously, at a national level, we are doing some very exciting policy work on what a futuristic GP and primary care service would look like. And we've undertaken and successfully undertaken a number of pilot projects. Let me draw your attention to one such project, which is a GP surgery in Buckhaven, which has adopted what is called the Alaska model. Now, what happened, as the name suggests, this was developed in Alaska. And what they found in Alaska, which is a very small population covering a huge area, that something like in Alaska, 70% of visits to GPs were unnecessary, in that the patient did not need to see the GP. In fact, would be better off seeing another type of professional, a podiatrist, a psychiatrist, maybe the nurse practitioner or whoever, but they didn't need to see the GP. Only 30% of the people who were going into the GPs in Alaska, they reckoned, needed actually to see the GP. So they've redesigned the services so that basically the 30% who need to see the GP, maybe a suspected cancer or something like that, they see the GP. And instead of having just a few minutes with the GP is spending much longer with each patient and is getting much more to the root of the problem and spending much more time to make sure that there is a proper care pathway in place for them. Meantime, the other 70% are also much happier with the care they're getting because they're going direct to the professional they need to see, whether it's a podiatrist or whatever. And the system appears in Alaska to be working very well. One of the projects we've done with the GP in Buckhaven, GP practice, is adopt the Alaska model. And I was talking to him 2 weeks ago, just before the recess. And he says, while he doesn't think the 70-30 is the case in Scotland, it's maybe more like 60-40, he believes the Alaska model is one way in which you can improve dramatically the service available, primary care services, to his patients. So these are the kind of initiatives that we need to be looking at for the future in order to not only manage the demand better, to manage the pressures better, but actually, most importantly, to make sure that the patient actually, as quickly and directly as possible, gets the actual service they need, rather than always necessarily they think they need, or the one they say they want when they phone up for a GP appointment. And that then, also I think we also need to be, and we are talking to the BMA about the future of the GP contract, because in terms of the future design of GP services, there's now such an increasing divergence between what's happening north of the border and what's happening south of the border, that the GP contract that is being negotiated for the English Health Service is increasingly not fit for purpose for Scotland, and that's the kind of conversation we need to have about the future.
Thank you, Cabinet Secretary.
GP contract, what timelines are we working on that?
Well, the contract's renewed, the terms are changed by negotiation every year, and at the moment it's a UK negotiation. But last year we made quite a number of significant changes in Scotland. In particular, we reduced the bureaucracy imposed on GPs to free them up to do the other things they need to do. And I would like to go much further in reducing the bureaucracy we ourselves impose on GPs and free them up to do the job they're there to do.
I think it has been discussed there that they're essential to this transformation and how we deliver care in the communities. So how much is in the budget to incentivise that? Because usually, I think that's the polite way they put it, but the change only comes after incentivisation for GPs, I think.
Well, it's rather, I mean, obviously we'll get the primary care services in the budget, convener, but in terms of incentives, as you put it, or removing disincentives, that's really done through what is called the QOF, which is essentially the core of the contract with the GP.
Will you be able to do that within, not cost you any more to get this new way of working? Or?
Well, we have to agree the way forward. There's a strategic discussion to be had.
Yeah, but you get into the negotiation, you haven't thought about what you're wanting or what you're going to have to pay for and how much it's going to cost.
No, I don't think this is a transformation that can be done in 12 months. This is a longer-term discussion about the strategy going forward.
So you don't see any progress in that for 12 months, or we'd have to pay up money after that?
No, I'm sure we'll make progress. I mean, as I say, we've already been running a whole range of pilot projects with different GP practices across the country. We're also doing some innovative work, particularly with the 100 deep-end GP practices, and that's very useful as well.
You know, I was just trying to get the shape of the negotiation.
Yeah.
You know, about. Anyway, we'll read about it, I suppose. In terms of the change agenda and the significant money, did I pick you up right in saying that we'll not have any real evaluation of that for a couple of years?
No, there's been the evaluation of individual projects, but what we need to do is a proper evaluation of the change funds as a whole, to look at the total impact that they have made, and we also need to look at what's mainstream, what's not mainstream, what's what, what's not what, you know, what lessons can we learn from the whole change fund programme.
But given it is a substantial amount of money that's been transferred over, and we've got performance indicators and finance is tight and precious, are we just taking the chance that for another couple of years, or the years previously and another couple of years, that we can just spend this money and then find out as a result of the review that we didn't spend money wisely?
No, we do monitor the projects as they go forward, and the health boards themselves monitor the projects. But this is at an overall evaluation which is done, with all these programmes in the health service. Once something with a definitive lifespan comes to an end, there is always a comprehensive evaluation of the entire programme. There are individual projects ranging in terms of the budget from very small amounts to quite significant amounts. They will have individual evaluations, and that will also feed into the programme-wide evaluation.
So have you evaluated some of these projects or boards and stopped any of these projects?
Some of them have already been evaluated on an individual project basis. And we'd be happy. I think we can probably tell you which, send you details of which ones those are.
One final one, the personal one, a constituency one. You mentioned the funding model and then RAC funding model. I don't think I would agree from representing a declining population in the community that's got deprivation and significant numbers of above the Scottish average elderly, that there's a fair distribution based on need, when population is the dominating factor in terms of allocation funding. Do you intend to go any further to recognise the inequalities in that system and change that system to improve the inequalities?
Well, it's designed to do that, but of course the NRAC formula that we apply is between the health boards. What obviously the health boards then have to do is to translate that into how, in your case, how much do they spend in Glasgow, how much do they spend in Paisley, how much do they spend in Inverclyde, and so on. So I would refer you back to your health board.
Yes. Well, I'm sure they're not claiming credit for a needs-based funding model, but anyway, I'm happy with that. Mark MacDonald and then Gil Patterson.
Thank you, Convener. A couple of issues that have come up in the previous evidence sessions, and maybe a couple of personal hobby horses as well. First is around improvements to early intervention and diagnosis. I know that we've seen great improvement in terms of, for example, cancer. But there are other conditions, maybe not in terms of the life-threatening conditions, but I'm thinking in particular around areas like, for example, dementia, around areas like, from a personal perspective, autism and additional support needs, which obviously have a knock-on impact on other budget areas and the individuals' lives as well. What efforts are being made to drive through greater early diagnosis of conditions and greater awareness of conditions within GPs in Scotland? Because I'm aware that for some conditions it is still patchy around early diagnosis.
Well, actually, with both dementia and autism, they're actually very good examples of where we've made significant improvements in recent years. And I think I'm right in saying that the speed with which we are identifying dementia is the greatest speed in the whole of the United Kingdom. We've got a far higher proportion of older people, particularly, identified with dementia at an earlier stage than anywhere else in the UK. And that's as a result of a number of initiatives we've taken. For example, when people are admitted to hospital of a certain age, then, you know, there is an examination to if there's a prima facie case for doing so, obviously, and we're identifying far more dementia patients and identifying their dementia as patients are going into hospital than was the case previously. And similarly, the detection of autism is at a record level. I think the main challenge in autism is still catching up on the backlog of previous years, where people who are now in adulthood who suffer from autism and were not properly diagnosed while they were at school. I think that's probably the biggest challenge in terms of further improvement in diagnosis of autism. But as a general point, Mark, I totally agree with you. Early diagnosis is absolutely crucial, and throughout everything we're doing, we're trying to improve the rates of early diagnosis, because obviously in many of these conditions, if you take a child with autism, clearly needs a level of support that a child without autism doesn't.
In terms of the evidence we took recently from the organisations and the professional bodies, I raised the point around spend to save, and that often we will receive evidence as individual members from organisations or representative bodies saying, if you spend £1 on this, it will save you X number of pounds in the future. And I asked about modelling work that's being done to look at, you know, where that can be evidenced, and where health boards are aligning their budgets in such a way that they're taking cognizance of that. And the feedback that we got was that that's patchy at best in terms of health boards. So what work is being done? Is there work being done on a national level, or is there encouragement being given to health boards to look at what the added value, if you will, of the pounds they're spending is, to make sure that it's being spent in a way that will reduce budget pressures in future?
Yes, we do that where we can. I mentioned earlier, for example, the immunisation programme, and you can see from the budget that we're substantially increasing investment in immunisation, particularly in relation to children's flu vaccinations and to the shingles vaccination. Now, they're a very, very good example of spending to save, because it's far, far cheaper, as well as the right thing to do from a health policy point of view. It's far cheaper to immunise the population against flu than for them to take flu, and then in some cases have to be hospitalised, because flu, as we know, can also be a fatal condition. And similarly with shingles, which is a very debilitating illness for anyone, it's far better for the individual and for health outcomes to spend to save in immunising people against shingles, as we're now doing, rather than have them take shingles, because clearly once you've taken shingles, it's very difficult to shake it off, and it costs both the individual and the health service a lot of money to treat shingles. So these are two good examples, but obviously in terms of the overall approach, where we can, and part of the efficiency savings as well, is looking at where we should spend money to save money. And it is built into, I think it's fair to say, John, the LDPs as well, that we encourage the boards to do that. I'll ask John if he can give you some other examples that don't come, other than the ones I've just mentioned, if he can give you some other examples of where we spend to save and been doing it successfully.
I'll give you a couple of specific examples. The alcohol brief intervention monies is an example of the investment in that area to reduce the incidence and recurrence of the alcohol problems, and therefore saving money in the long term. The HI investment programme, again, is an example of spend to save, investing in some very basic infrastructure, very basic procedures within hospitals that reduce the level of infection C. diff down by over 80% across Scotland over the immediate period. Also, a very small investment, again, in mobile technology. We put £1 million out across NHS Scotland to get some initiatives and some pilots taken forward around a range of technologies. We were not prescriptive, and deliberately we're not prescriptive in terms of this is the solution, it must be DigiPens across Scotland. So we allowed a bit of local initiative in terms of what suited staff at a local level. So we're trying to do it with staff, rather than have a sort of central dictatorial approach in respect of that. There's numerous other examples I can give, but these are just a number that immediately spring to mind.
The point was, I made the point, and the point was made by, I think, by RCN at the last evidence session around it's not always the person who spends the money who gets the benefit, if you will, in terms of the savings. So it may be that, for example, money being spent in other budgets could have a positive impact on the health service because it would reduce admissions, reduce the occurrence of ill health. What discussions are taking place, and I suppose this ties into the health inequalities agenda as well, where we know that often the health inequalities from a health service perspective are people are arriving there with the health inequalities having already manifested themselves, and there are other budget areas that need to be looked at. So what work is underway from yourself, Cabinet Secretary, to discuss with your colleagues when they're looking at their budgets, how they can tailor some of their budgets to impact on, for example, the health inequalities agenda, but also to maybe derive benefit to the health service through reduced admissions and other issues like that?
Well, these discussions take place at cabinet level, at ministerial level, when we're looking at the overall budget considerations. But also, as you know, we're all involved, being led by John Swinney on behalf of the whole government, in reforming the community planning partnerships, because very clearly, and John made some announcements in his budget statement on this, because if we can get through the community planning partnership, local authorities, health boards, housing association, the whole range of gambit of organisations, before they decide their budgets on an annual basis, to actually talk to each other and look at where they can maximise the impact of their budgets and allow each to comment on the proposals of the other, then we believe that we'd get a much more joined up approach to tackling particularly inequality, but also a whole range of other issues. Already on the initiative and being developed and led from the health service point of view by Sir Harry Burns, the Chief Medical Officer, one of the areas we think is very important, not just in terms of the budget, is actually on data sharing. And already there are very effective arrangements in Forth Valley, for example, and in Fife, and in Edinburgh and many other parts of Scotland, where there is a multi-agency approach to sharing data, where you identify very often that the problems in particular families, the same families are involved maybe with the police who are involved in a range of other problems, say in education or in health and a whole range of things. So that's another way in which we're trying to, at an operational level, get far, far more cooperation and sharing of data between agencies, so that between them they can intervene much more effectively. Within the health service, we're actually doing that with social care as well. For example, in the parts of Edinburgh, there are teams that meet every week and literally go through individuals and families who require multi-agency support within the health service and between the health service and other agencies. And again, I think that's an effective way of maximising the impact of interventions by all the agencies, but it also leads to a much wiser use and a more effective use of the money.
And obviously, the point that was made was, we have to have oversight of the health budget, but we have to also have cognizance of the fact that there are other budget decisions being taken elsewhere in the Parliament, in the government, that will have an impact on the health budget and going forward. One other issue that comes up all the time is around maintenance and the health estate. We obviously had a discussion at the last budget around what was perceived as a maintenance backlog, and I think you addressed a number of those that were being addressed through, for example, delivery of new facilities, which would remove facilities which had a large amount of maintenance backlog attached to them. Where are we now in terms of the maintenance backlog landscape in terms of the health service?
To get John to supplement this, but let me just generally say we have a very robust estates management strategy, and we'll be updating that again shortly, as we do on a regular basis. And we have been deliberately in asking boards to allocate resources, particularly to the high risk and significant areas in terms of backlog maintenance and repair. And we believe that by 2017, we will have completely wiped the slate clean in terms of high risk and significant backlog. And much, not all of, but a fair chunk of what is left is actually in relation to surplus buildings, surplus land. And of course, one of the reasons why the gross figures look as high as what they are today is because many of these properties would have been sold off because of surplus to requirements, but because of the property crash in the last 5 years, that's not been possible. If you look at NHS Lanarkshire, they have the Law Hospital site and they have the Hatwood site, both of which have been difficult to move because of the state of the property market. So the overall, the gross figure is inflated because of the slowness in being able to dispose of distressed or surplus property, particularly in tougher areas. There are some markets like Edinburgh, St Andrews or Aberdeen where it's a lot easier to dispose of surplus property than it is in many other parts of the country. But in terms of the high risk and significant projects that have been identified previously, in terms of the backlog, we'll have cleared that, I think I'm right in saying, John, by 2017. Is that right?
The high and significant will be cleared by 2017. That will be achieved through three aspects. One is some supplementary movement from resource to capital to increase the capital budget. And that is £320 million over the current spending review and will continue into the next spending review. And we will also have, as a result of that, an increase in the formal allocation that boards will receive to deal with the high and significant ends, or deal with the currently identified needs in terms of high and significant end. And that formula capital budget will increase by 25% between 13-14 up to 15-16. The capital investment programme that we have in place, both the stuff as Cabinet Secretary identified that is currently delivering and will conclude over the next couple of years, like the new South Glasgow project, as well as projects which are advanced and in the pipeline. The Dumfries and Galloway Royal Infirmary project is now down to 3 bidders, and they will be at 2 bidders by January. So that investment will deal with that. In terms of the macro position, the total backlog maintenance has reduced by £80 million over the last year as a result of the investment that I've just described. But the capital strategy that underpins that is driven by the overall quality strategies. The capital strategy is not to sit in isolation, but where we're going to invest going forward through Dumfries and Galloway Royal Infirmary, Ayrshire Narren, the new blood transfusion service, the Balfour Hospital up in Kirkwall, and the sick children's moving from the city centre down to the new Royal Infirmary is all driven by the quality strategy, as indeed is, going back to an earlier point that the convener made about community investment. There's a significant investment in the health centre facilities as well being taken forward.
The convener made the point about the areas of declining population, and if I can flip that and talk about where I represent and the area around where I represent, where we are seeing significant development taking place, communities growing, new communities being created, and that obviously has an impact on the existing health service infrastructure and the requirement for new health service infrastructure. What discussions is the Scottish Government having with boards like, for example, NHS Grampian and other boards where there are going to be population explosion, if you will, or at least increase in population and an increase in demand, to look at how they can cater for that demand?
We have very detailed discussions and ongoing discussions at every level. You know, I speak to the chairs and the chief executives and the chief executive, acting chief executive of NHS, and John's in regular contact with the senior management teams in Grampian and every other board and his team at every level. We do recognise the particular challenges in Grampian of a growing population, and also with it the challenges, for example, in terms of the labour market challenges and their knock-on impact on the health service. I mean, one of the challenges we have in the Grampian, particularly in the Aberdeen city area, is in relation to nursing home places because of the difficulty in getting people recruited to work in nursing homes in Aberdeen because there are so many other jobs available with higher wages and all the rest of it. So we're very, very cognizant, and also in terms of the NRAC formula, we're very cognizant of obviously that we've not completed the process that's been started, and Grampian is the area where the process has to be completed to reflect the increasing population in the Grampian area.
But if I may link back to your previous point, when there's been the emergency care centre investment at the main acute site in Grampian, Dr Gray's is getting some additional investment. We've given another £10 million for backlog maintenance investment on acute services within Grampian. The Aberdeen Health Village will transfer across next month. We've got the Woodside and Forest Health Centre investments. There's Inverurie is at an early stage but progressing well. So there's a number of initiatives. So we do recognise the problem that you highlight, but in terms of the capital infrastructure, not just on the acute side but also on the community side, we're working very closely with colleagues in NHS Grampian to progress that.
You make a valid point, Cabinet Secretary, about the particular pressures in the North East around recruitment. Obviously, there is the buoyant oil sector where people can go and make a lot more money than they would make in the public sector, and that affects not just the health service but also the council, police and other agencies. Is there work underway to look at possible solutions to this very localised conundrum?
It's not just in Aberdeen. I mean, we have similar pressures in other parts of the country, particularly Edinburgh, obviously. But one of the things in the National Health Service is pain conditions, generally speaking, certainly for the large bulk of workers, are decided on a negotiation that's done either at a Scottish or a UK level. And there is no provision for regional variations or regional pay, and nor would I argue particularly for that. But we do recognise that there are pressures, and therefore I think the pressures tend to be more, if you like, in the lower grade jobs rather than, you know, a consultant. It's not particularly, you know, consultants are not likely to be going to the oil industry. But other people, you know, particularly, say, technicians. I mean, it's not just, let me give you an example in the Western Isles. One of the most difficult challenges in the Western Isles is finding a maintenance engineer to work in the health service. And the reason for that is not the oil industry, it's the success of the renewable energy sector in the Western Isles, because people can earn much more money in the renewable energy sector in the Western Isles if you're a maintenance engineer than you can working for the National Health Service. So there are undoubtedly challenges in different parts of the country, and we do try to meet those challenges, but obviously we don't want to go down the road of regional pay variations.
Nor would I encourage you to do so, Secretary. Thank you, Convener.
Bill Patterson.
Thank you very much, Convener. We go from the richest parts of Scotland in Mark's question to some of the poorer areas. In my question, I know that Cabinet Secretary you mentioned, and we very much appreciate that the health budget for the year we are scrutinising and beyond is protected. So we understand that. But I wonder if you've looked at projections with the impact of the welfare reform that's taking place and how that's going to impact on the budget in this fiscal year.
We are looking at the impact of welfare reforms, and it's at different levels. There's an impact at the operational level, and one of the major issues has been the amount of time GPs are having to spend writing letters for the Department of Work and Pensions, and that's obviously been quite a controversial issue and a difficult issue for GPs, because obviously while they get paid for most of it from the DWP, nevertheless, in terms of it's a very time-consuming activity. But also, what concerns me more is the impact on the health of individuals, because there's no doubt, and I know as a constituency MSP myself covering a deprived area, the impact on the adverse impact on the health, both physical and mental, of people who are at the receiving end of many of these cuts. And bear in mind that the disabled have been particularly badly hit by some of these cuts, is having a major impact on the health of people. Now, it's difficult to quantify that, but we are keeping very much a watching brief on it. And of course, most of the cuts are still to be implemented. I mean, we've had postponement in terms of the replacement of the disability living allowance with the PIP, and that won't now be introduced in Scotland as quickly as had been planned. But if you look at the overall impact, I mean, I can see, for example, the stress that is being caused by the so-called bedroom tax on individuals. And I've certainly had people at my surgery extremely distressed about how they're going to make ends meet, how they're going to feed the family. I actually had a single mother in my constituency recently, and she had 3 children with autism, and she'd been left by the Department of Work and Pensions with £18.50 to live on for the week. And she was at the end of her tether.
Well, the point that Bob Doris made earlier on in regards to the budget, the fact that the government, it's very much in the government's control to protect the health budget, but of course it's got an impact in other parts of the Scottish budget, and again we understand that. But since we kind of know that there's going to be a serious impact fairly soon caused by the welfare reform, is there contingencies in place? Is there money set aside, or is it the budget as it sits at the present time? Is that it?
No, must
we work within that?
I mean, it's the budget as it is. I mean, John Swinney, I have to say, has got a very difficult job indeed, because the pressures that are being put on our budget as a result of the consequences of some crazy decisions being made elsewhere. I mean, for example, we are having to allocate, and we do not do this grudgingly given the circumstances, but we have to allocate £20 million from the Scottish Government budget this year, and the First Minister has committed the same next year to help alleviate the impact of the bedroom tax. Now, quite frankly, we can ill afford to spend that £20 million given the tightness of our budget. Our overall budget as a Scottish Government this year is about 12% below what should have been expected, and on capital 26% below. So it is a very, very difficult situation, and there is no spare cash because we're having to, it's not just those funds. We've had, for example, to fund the 10% cut in council tax benefit to stop people ending up in total despair who just don't have the resources to pay it. I feel sorry for the people south of the border because they don't have a Scottish Parliament to protect them from that 10% council tax benefit cut. But there is what you see in front of you is the totality of the money available to us for this portfolio. And I would not anticipate receiving any additional funding whatsoever, for the simple reason that the cuts being imposed by London leave us with that. We don't have that extra money, and at the moment we don't have the power to borrow or to tax ourselves. So it is a fixed budget we're living on, and it's a fixed budget with increasing pressures anyway, but totally unnecessary additional pressures resulting from these crazy welfare changes.
I'll just leave you with the fact that by working a bit smarter, we might be able to do a bit more with the same amount. Maybe that's just my
But we're also restricted by the rules. I mean, we would like to do more, obviously, and if we had the money, we would be doing more, for example, to alleviate some of the welfare changes. But in law, we're only allowed to spend £20 million to alleviate the bedroom tax. In law, we have no choice. The people calling for a £50 million spend in that, how do you defy the UK law? Reserve legislation says that we can only spend £20 million on doing that.
Yes, thanks, Convener.
Well, those who don't totally agree with all of that resist the opportunity of engaging in that whole debate, because we have come to the end, I think, unless there's any other urgent questions from the committee.
with it.
Yeah, well, he's forever helpful. He's a lawyer. Gunga Din. You're a better man than I am, Gunga Din. But I don't think there is any other questions. We have had a good session. It's always a pleasure, Cabinet Secretary.
Absolutely.
Mr Matheson, thank you for your attendance here this morning and your help to the committee. We briefly suspend now, just for a comfort break, but we're back into private session as previously arranged to see if we can get any progress on the paper before us here today. Thanks very much. Thank you.